I want to welcome everyone to the Rover 2023-24 academic year. Welcome to everyone for the new academic year, probably for med students just starting med school and for residents who are just starting their next year of PGY, whatever. Today we have a very exciting session on treatment management. Just some ground rules. If you have any questions, put it into the chat. And when you put in the chat, try to put it to everyone, not just hosts and panelists. So everyone can see the question, and we'll try to answer those as we go along. You can also put it into the Q&A. So we'll also try to keep an eye on both of those. And with that, I'm going to hand this over to Jacob Hall.
Thank you, Dr. Khan. Yes, my name is Jacob Hall. I'm a resident at UNC, and I'll be moderating today. As she mentioned, we do encourage everyone to please fill the chat with questions as the session goes along, and I'll be keeping an eye on that and kind of filtering those, and we'll kind of raise those at times throughout the session. And amongst the panelists, it's certainly encouraged to be a discussion, sort of case-based format. So, interruptions and comments and questions are encouraged throughout the 1 hour session today. So we do have three fantastic all radiation oncologists with us today. First is Dr. Emma Holliday from MD Anderson, who mostly specializes in GI malignancies. We also have Dr. Daniel Ma from the Mayo Clinic, specializing in head and neck cancer, and he'll be talking about on-treatment management for those patients today. And we have Dr. Pamela Sampson from WashU, who primarily treats thoracic primary tumors. So with that, we will get started, and I'll hand it over to Dr. Holliday.
All right. Can you guys hear me okay? Great. So we'll start off with two cases of common toxicities in the treatment of patients with GI malignancies. We'll do one from the lower GI tract and one from the upper GI hepatobiliary tract. We can go to the first slide. And the next one. There we go. Okay, so here's the case. It's a 35-year-old woman who I was treating with long course chemoradiation for locally advanced rectal cancer. You're my resident or my student, and you are seeing her with me in Weekly C Clinic, and she's at fraction 16 of 28. She reports she's not doing great. She's having diarrhea about once an hour during the day, and also, getting up multiple times at night for this diarrhea. She's already taking 1 to 2 tabs of loperamide every 2 to 4 hours, and she's alternating that with 1 to 2 tabs of diphenoxylate atropine every 2 to 4 hours. Pretty much max dose of both without relief. So you're now in the driver's seat. Please participate by putting your answers in the chat. The first thing you need to ask yourself when you're seeing on-treatment toxicities, is this expected based on what we're doing to this patient in her treatment, or is this unexpected, something that we need to do some further investigation on? What do you guys think? 50-50 chance. 1 vote for unexpected. Yeah. Yeah, so some split opinions. Let's go to the next slide. Yeah, so what we're seeing here fits squarely into the category of grade 3 diarrhea. By most grading scales, that's defined as having more than 7 to 10 bowel movements or greater than 7 to 10 bowel movements per day over baseline. So this is, bordering even on between grade 3 or grade 4. How common is it to see grade 3 diarrhea at all during pelvic radiation? It's not totally rare. Based on the German study looking at long course chemoradiation as a component of total neoadjuvant therapy, the acute grade 3 or greater GI toxicity rate was somewhere in the neighborhood of 15 to 25%. However, I would argue that seeing this degree of diarrhea, really just, the end of week 3 of a 5-week course is a little bit early and a little bit severe compared to what I'm used to seeing. So usually we think of acute toxicities kind of slowly increasing in severity up to the end of chemoradiation. Really, they usually reach the peak of severity 1 to 2 weeks after the last day. and then kind of slowly get better over time. So this, although we do see grade 3 diarrhea, it can happen with long course chemoradiation for rectal cancer. Something just seems a little bit off to me about this lady's case. So let's go to the next slide. So, kind of thinking a couple steps back, what can we do with acute lower GI toxicity in mind to be proactive and try to, give it our best shot during the simulation and treatment planning phase to reduce the risk of grade 3 or greater diarrhea? The first thing that we rely a lot on when we treat lower GI cancers is gravity and position. So we know that there's 2 ways we can help physically displace the bowel from the area where the higher dose radiation is going to come in. One is to position folks prone on a belly board. The second, if you're treating them supine, is to ask them to come with the comfortably full bladder. You can see by the pictures I've put here, for most folks, being prone on a belly board, gravity helps to displace the small bowel away from the posterior pelvis, where we bring in the higher dose. And with a full bladder, you can physically displace the small bowel more superiorly and anteriorly. So this woman was treated prone on a belly board, so we had already done that. There are also some evidence-based constraints within the literature that we keep in mind and utilize in our planning directives to try to keep dose away from either the small bowel loops or the bowel bag. You can ask 100 radiation oncologists and you might get some split opinions on which the best organ is to use and to constrain. So I'll leave those there for your reading pleasure another time. Let's go to the next slide. Okay, so to me, something seems a little bit off about such severe toxicity relatively early in, a very standard long course chemoradiation course for rectal cancer in an otherwise young and very healthy woman. So drop some answers in the chat. If you're seeing this lady, what would you like to do? What tests do you want to order? What, studies would we consider, interventions? Just, what would you recommend to your attending, or what would you do if this were your patient? Rule out C. diff. I see that in the chat. What else? Kind of even before that, the patient's sitting in front of you in the clinic room, pooping every hour, having lots of diarrhea. Look at the plan again. I like that. Yeah, so check labs, vital signs, right? Make sure the patient's hemodynamically stable. And most likely, nobody can drink enough water to keep up with having diarrhea every hour. So for sure, IV hydration is super key. Let's go to the next one. Okay, so yeah, here's my little mental checklist. Anytime I see diarrhea that's out of proportion to what is expected, or anytime I see severe diarrhea, I always want to make sure, you do the first principles of medical school, right? You make sure that the patient is stable. If the vital signs even look a little bit squirrely, I ask our nurse to check orthostatics for us. Make sure that the labs are up to date, or send the patient for repeat labs to check for the basic electrolytes. If folks are having a lot of diarrhea, the first things to waste or to go down are potassium and magnesium. Like someone said in the chat, take a look at the plan again. I always do that. Just, we're all human. We can all overlook something when we're checking plans. So make sure there's not anything I missed about hotspots or about the amount of bowel getting 45 gray or more. And then I go back and take a look at the last few days cone beam CTs and make sure there wasn't some kind of, change in anatomy that somehow I overlooked. So it's always good to double check your work there. Someone very smartly mentioned C. diff. That's always on my radar for someone who's got diarrhea out of proportion to what I usually see at this stage in treatment. The kind of red flags for that particularly is if the diarrhea is particularly foul smelling, very watery. If there is any fever obviously associated with that, you want to send stool studies for C. diff and also other ova and parasites. Actually thought that's what was going on here. I sent this woman's stool for C. diff testing. It was negative, so that wasn't it. The other thing we need to keep in mind are the zebras. So one thing, when we treat patients with rectal cancer with chemoradiation, usually what goes along with that is either 5-FU or Xeloda. And there is a genetic condition or predisposition called DPD deficiency. You may remember this from somewhere in biochemistry way back in the day, but folks with DPD deficiency can't process or metabolize 5-FU and the oral cousin of 5-FU, capecitabine. So it builds up in the bloodstream and it leads to exuberant toxicities. So I always think of DPD deficiency if I've got somebody who's on 5-FU or capecitabine who has very early diarrhea out of proportion to what I would expect, and diarrhea that comes along with things like cytopenias and mucositis. Those are the other two things that can come along with exaggerated toxicity to 5-FU or capecitabine. So after the C. diff came back, I actually really thought that's what was going on with this patient because she was getting oral capecitabine. We sent that out to the lab and I was surprised, but it came back negative. So we looked for both of these things and couldn't attribute her diarrhea to that. So let's go to the next slide. So, all right, we've assessed the patient. She's stable. We started her on IV fluids, kind of a standing order to get IV fluids after radiation every day. She's already taking maximum doses of Imodium and Lamodal, which are my choice 1 and choice 2 for diarrhea management. She's maxed out on those. What would you do? What would you order for her to help get this diarrhea under better control? Drop it in the chat if you don't mind. Anybody? No brave souls? Treatment break. Yeah, you certainly could consider it. We definitely held her capecitabine, or her medical oncologist held the capecitabine until the diarrhea got below a grade 2. So we did that. We talked about a treatment break for radiation, and that would have been in the cards if we hadn't got it under control. But there's a little bit more medical management that you can try, or that we did try before getting there. Sandostatin, yeah, that's an option. I think some of our docs will do that inpatient. I haven't given that in the outpatient setting before. Maybe you could in an infusion center. Let's go to the next slide. Yeah, so here's kind of my diarrhea management algorithm. And choice 1 and choice 2, we had already maxed out for this particular patient. What I usually go to as third line, and I learned this from the great Dr. Minsky, who's at MD Anderson now, was at MSK for a long time, is tincture of opium. It's old school med. Sometimes, depending on the pharmacy, it's hard to get it or it takes a while to get it, but it works remarkably well for refractory diarrhea. So I don't use it very often, maybe 1 or 2 patients per year whose diarrhea is just super hard to control. I do always take a step back, go through those checklists that I showed y'all to make sure I'm not missing anything, one of these kind of more rare causes of diarrhea on treatment before I prescribe it. But when I've used it, it's always worked well. So you can alternate that with Lamodal and Imodium. And for this patient, it really was the magic bullet she needed to help maintain her hydration, help get her nutrition back under good control, and to finish treatment without needing a break. So that's what we did there. All right, so upper GI toxicity, this is a shorter case. Next slide. So here's a 67-year-old gentleman. I was treating him with hypofractionated dose escalated radiation, 60 and 15, for a locally advanced unresectable head of pancreas adenocarcinoma. I saw him at his first weekly C. I do those on treatment visits on Fridays. He was feeling awesome. And the next Tuesday, he sends me a little MyChart message through our electronic messaging portal. And he said, hey, doc, over the weekend, I started getting a little bit of a fever and chills and started getting some abdominal pain. And my wife said my eyes and my skin are yellow. What should we do next? Quick, drop it in the chat. Yeah, so agree. We need some blood work with the scleral icterus and jaundice. Certainly concerned for some sort of, liver issue, maybe some elevated bilirubin. Let's go to the next slide. Most importantly, I wanted to lay eyes on him. So depending on what time of day this message comes in, I got this message in the morning. I said, hey, come into clinic. Let me examine you. Let me get a set of vitals. Let me assess what's going on. and go from there. So I saw him, he was hemodynamically stable. He did have a low-grade fever. So I sent him to the labs to get some information on what's going on. I saw there was elevated white count with the left shift, and I pasted his labs up on the slide. And the thing to notice is the total bilirubin 6.2 could definitely be responsible for his jaundice and sclerolicterus. For most folks, at least of Caucasian coloring, you can start to see sclerolicterus and jaundice with the bilirubin around 3. So this tracks with what we're seeing on physical exam. We also see elevated AST and ALT, suggesting some liver inflammation, and elevated alkaline phosphatase, which further supports like an obstructive picture. So let's go on to the next slide. What I was worried about with this picture of fever, of right upper quadrant pain, and now with, confirmed hyperbilirubinemia is cholangitis. So you probably remembered this dead guy, Dr. Charcot, who has a triad named after him, and fever, right upper quadrant pain, and jaundice should make you suspicious or worried about ascending cholangitis. And we can see that sometimes, come on rather suddenly when we're treating somebody with a hepatobiliary primary during radiation. What can happen, what can cause this is either there's a little bit of tumor inflammation that takes a partial obstruction and makes it complete. More rarely, there can be tumor progression, or there can be, stent malfunction if a stent is already in place. So anytime you suspect cholangitis, pause, break radiation. I send these patients to be managed inpatient so they can get IV antibiotics. Piperacillin tazobactam is the medication of choice for that. Rarely you can manage very stable or early ascending cholangitis with oral antibiotics, and the combo for that would be Cipro and Flagyl. The other thing you need to do is consult your GI colleagues to relieve the obstruction, because you can give all the antibiotics in the world, but unless you restore normal biliary flow through the area of tumor obstruction or inflammation, the patient's not going to get better. So usually our GI colleagues will get involved. If they don't have a stent, they'll have one placed. If they do have a plastic stent, it'll be replaced. If they have a metal stent, it will be manipulated or cleaned out to restore flow. So this is, not something that's super common, but does, happen. I see this in clinic probably 5 or 10 times a year. And I have a reasonable volume of hepatobiliary primaries, and it's just important to be vigilant for and to recognize early, because these people can get sick very fast and develop biliary sepsis. So being proactive and starting antibiotics and sending folks to GI to get the flow restored is super important. So we'll go to the next one. I think that's it. That's all for me.
Yeah, thank you, Dr. Holliday. That was excellent. I don't see any questions at the moment in the chat, but there are a couple that I have. I'll save until the end. So next up, we have Dr. Dan Ma. I think you're muted, Dr. Ma. I don't know if we should skip to Dr. Sampson in the meantime, or maybe give it another second to see what's going on.
Yeah, why don't you go on to Dr. Sampson?
All right. Well, thank you for this opportunity, and thanks for being with us on a Friday afternoon. So yeah, let's go ahead to the next slide. Do I have control or? Okay. So I'm going to give a couple examples of on-treatment toxicity from traditionally fractionated lung cancer cases. We do a lot of SBRT also for early stage disease or oligometastatic disease, but because those courses are so short, Usually people, we don't see much on treatment toxicity other than maybe some sore shoulders from, having to hold a SBRT position, or they may have some fatigue for a few days after SBRT. So typically those OTVs are very straightforward. I talk to them about next steps in their cancer care. So for this, I'd like to focus on traditionally fractionated RT courses. So the first case is a 72-year-old female with a history of clinical T3N2M0 non-small cell lung cancer of the right upper lobe, and she's receiving definitive intent concurrent chemoradiation therapy, 60 gray and 30 fractions with a VMAT plan. In the first 3 weeks were very standard, pretty uneventful other than some mild fatigue, decreased appetite, change in sense of taste due to chemotherapy. Decreased appetite and changes in taste can be very, very common with the chemo regimens they use for non-small cell lung cancer. But by week 4, she has started to notice some increasing dysphagia and odynophagia that is causing even a further decrease in PO intake. So similar to Dr. Holliday, would this be expected or unexpected? If you want to drop it in the chat. Yeah, so I agree with that. It would be expected. And the key here is that I've told you there's N2 disease. So there's disease in the mediastinum, which would imply that our dose is going to be close to the esophagus. So what would be some next steps in the management of dysphagia? What are you trying to rule in or rule out? And how would this on treatment visit go for you? If you just want to shoot some ideas in the chat. Yep, Carafate, Magic Mouthwash, agreed. Those are pretty much the most standard treatments. All right, next slide. So during OTV, I kind of approach this systemically. So you always, on these patients getting concurrent chemo RT, first off, you always want to check for oral candidiasis. So usually by week 4 of chemotherapy, their white count can start dropping, and between the stress, poor nutrition, decreased white count, this can put them at risk of oral candidiasis. So sometimes it's this, which can have extension into the esophagus. So I'll often ask patients when they're complaining of odynophagia, where does it hurt? So I'll ask them to point to me, where do you feel food getting stuck, or where do you feel it hurting? And if they're pointing up here, and I know I'm treating a subcarinal node and that my field is nowhere near there, then I'm looking for other causes, maybe some candidiasis. However, if they're pointing to their, the bottom of their sternum, that would be more consistent with treatment effect. You want to obviously check weight, vitals on these patients. And if they're having any, pre-syncopal type symptoms, dizziness when standing up, you want to check orthostatics on them too. And so the medical management of odynophagia, I do for a lot of these people, they're already on a PPI, but if they're not, I put them on it. Magic Mouthwash, which varies, the combination varies from institution to institution, but usually it's some combination of viscous lidocaine, an antihistamine, and a steroid. I always tell people to make sure that the pharmacy where they would like to pick this up does not have a compounding fee. That's just a good thing to know when we think about financial toxicity of what patients have to pay for. So at a lot of hospitals, they will not charge a compounding fee for Magic Mouthwash, whereas if you send them to like a Walgreens or something like that, they may actually pay out of pocket more for that. So I always tell them, if it's over a certain price, I want you to call me and I'll call it into our pharmacy. And then if that's not doing the trick, one that I have found works nicely is liquid oxycodone, because that has some topical effect in addition to the systemic effect that they would get from it. Also, I didn't put it on the slide, but also sucralfate is one I can add on as well. And I've had some patients get relief with that they weren't getting with Magic Mouthwash. With Magic Mouthwash, I tell patients you're either going to love it or hate it. There seems to be no in between. Some people don't like the how numb it makes their it can make their mouth and throat. And then finally, a nutrition consult. How much is too much for liquid oxycodone? I will usually start at just a 5 milligram liquid equivalent. So just like you would write the medication for a 5 milligrams Q4 to 6 hours PRN. I would do that way and titrate up. Viscous lidocaine. Yeah, there has been a lidocaine shortage lately. So I have relied a little bit more on sucralfate the past couple months than when we have had shortages of viscous lidocaine. That was a great question. Sucralfate, you have to warn the patients. Sometimes it's dispensed in a way that they have to mix it up themselves. So the pharmacist should be doing education with them, but I always like to let the patient know that. And then obviously a nutrition consult. It's possible that during this time we have to switch them to like a soft diet and avoid really hot liquids, really cold liquids. Those can further exacerbate any esophagitis that they're having. And then what about after the OTV? Anything you want to do after the OTV? Kind of similar to Dr. Holliday's presentation. Next slide. Thank you. You want to, I would be checking these port films every night, obviously, but one thing I pay attention to when people present with bulky N2 disease is by week 3 of treatment, these patients can be having really impressive responses. And it's always really nice to show those images, those port films to the patient during their OTV, because it gives them some visual feedback of what's going on with their tumor. And I found that patients really appreciate that. But another thing is, if I know a patient their disease is being a quick responder, that esophagus, as well as the airway, as well as the great vessels, can start to fall into that space, into your PTV. So while a treatment plan may have initially met esophageal constraints, as the disease responds to treatment, that may cause the esophagus to fall into a high dose area. So when you're checking port films, or when your attending is checking port films, it's important to not only just look at your tumor alignment, but also your organs at risk. So I will turn on not only my PTV contour to check for tumor alignment, but I'll turn on my esophagus and my airway contour. And that'll give me just some quick visual feedback of if my esophagus is starting to fall into the high dose area. And if this has happened, if this is what's going on, you can do a resimulation and offline adaptation to account for anatomical changes, and just give the patient like a 2-day break while you're getting that ready. Obviously, there's some exciting technology coming up that will allow us to do more online adaptation as our imaging quality improves with cone beam CT. Okay, next slide. And then this is just a way to try to prevent grade 3 or greater esophagitis. This is from Dr. Henning Willer's group that kind of took the same approach to esophageal sparing, similar to what GU radiation oncologists do with the prostate and the rectum. So they still maintained a max dose for the esophagus, but they would not allow, they additionally put on a circumferential constraint so that the high dose could only go to part of the esophagus, and the other half of the esophagus had to be below a certain dose. And you'll notice here that this was actually part of a dose escalation trial their group was doing. So typically we take patients to 60 gray and 30 fractions or 66 gray and 33 fraction. Their group was going to 70 gray at 2 gray per fraction for people with locally advanced lung cancer. And they used this partial esophageal sparing technique. And interestingly, the rate of at least grade 3 esophagitis was 0%, and there's a series of 25 patients. So again, a small institutional series, but especially at that dose and fractionation with mediastinal disease, I would have expected their at least grade 3 toxicity rate to be upwards of 30%. So this was pretty exciting. Next slide. And this is just some figures from that manuscript that was showing how they optimize based on the esophagus to really protect that other half of the esophagus so that it would not receive circumferential dose. Okay, next slide. All right, our next case is a 74-year-old female, very similar clinical T3N2M0, non-small cell lung cancer of the right lower lobe, receiving the same treatment, concurrent chemo-rad, 60 gray 30 fractions with a VMAT plan. And of note, this patient was diagnosed after being treated by her internal medicine physician for pneumonia twice. She's had 12 of 30 treatments completed, but during her OTV, she's noticed increasing cough, especially at night. And it's really bothering her. It's keeping her up at night, making her increasingly fatigued during the day. And she's noticed that the coughing can sometimes be so vigorous that it can cause retching or dry heaves. So pretty significant. What else would you like to know about her cough or these symptoms? Fever? Yep, perfect. Any other symptoms? Yep, at night or when recumbent. Great. Next slide. Yeah, so a lot of these patients that present with post-obstructive pneumonia from their bulky disease, they may have recently completed a course of antibiotics. And so if they've been off antibiotics for 1 to 2 weeks, I'll want to look at those port films and see if I'm concerned about the pneumonia not being able to clear just yet. So it's possible that they've had, a recurrent pneumonia from their obstructive tumor. I would ask any fevers, any increased shortness of breath, any hemoptysis, any choking symptoms while eating or drinking. Every now and then we can get tumors, bulky tumors that do invade either the esophagus or the airway that could cause or even a vessel that can cause these latter two symptoms, hemoptysis or choking symptoms. So you always want to check on that too. And she said her last antibiotics was 3 weeks ago, no fevers, no increased shortness of breath. She's just taking over-the-counter Delsym, but it's not helping at all, and no hemoptysis. Any idea what could be going on besides just possibly a recurrent pneumonia? Reflux, yeah. Microaspiration, things like that. Yep. Okay, next slide. So one thing to be considered, and not a lot of people recognize this, is that for patients that present with a post-obstructive pneumonia or a collapsed lobe at baseline, when treatment is underway, again, tumor response can start to allow that previously collapsed lung to reinflate. And when that's happening, they may notice increased coughing, including a really productive cough. And if the lobe has been down for some period of time, people can have really significant mucus plugging. So basically these hardened pellets of mucus that have been in the secondary and tertiary airways are now trying to come up. And so whenever a patient talks about they're coughing so hard, they're retching, they feel like they just can't get they'll call it the junk up. This is what I suspect is going on from these long collapsed airways. So how we typically manage this, next slide. I reassure the patient that it's usually limited to just 1 or 2 weeks as the lobe re-expands. This will not, if this is what's going on, this will not last the whole course of treatment. And then what I'll want is kind of a set of instructions for the patient to basically encourage good pulmonary hygiene as this is happening. So Mucinex to help thin the secretions. If they're having trouble sleeping at night, I'll actually write for codeine syrup that they can take at night. Tessalon pearls don't hurt. They're not always the best. It probably has the same effect as Deltin for this patient, but it's not a medicine that has much in the way of side effects. A humidifier, an incentive spirometer, what I call weightlifting for the lungs for these patients. And if the patient also has some pretty significant airway disease at baseline, I may consider a nebulizer for any inhaled agents that they may already be on. You really have to ask about this. It's surprising how many patients will have a symptom during their lung cancer treatment, like increased shortness of breath, chest pain, increased cough, and they don't tell you because they just assume it's part of them getting radiation to the chest. I've had a patient that had chest pain on treatment. He assumed it was due to the radiation, and we actually sent him to the ER. He was having a STEMI and had to be cathed like within 24 hours. I've had patients that, say they're getting increasingly short of breath. Sure enough, we do a CT PE protocol and they have, new subsegmental PEs and have to go on anticoagulation. So it's always really good at that first OTV because they will have probably forgotten from the time of consent. It's really good at that first OTV to remind patients of what side effects I expect on treatment and which ones I don't. And that I need to know any symptom they're having, because even though, I can treat the radiation ones, I want to, if they're having any other symptoms, I want to get them triaged to the right person. So if any of your patients are having what I call turbulence during treatment, sometimes it can take a team approach. Like Dr. Holliday was saying earlier, getting GI involved. Because so many other things can happen besides radiation. So just always have your eyes and ears peeled for that. I think that was it for me.
Yeah, I believe so. Thank you, Dr. Sampson. I do like the point that you just brought up at the very end about really educating these patients about what symptoms they might expect on treatment. Especially because a lot of these patients will have COPD or underlying lung disease and comorbidities and experience a lot of those symptoms sort of anyway when they're not getting radiation. And so clarifying that's really important. So Dr. Ma, if you are available and we have a working microphone, I'm going to advance or rewind back to your slides.
All right. Can people actually hear me now?
Yeah.
Fantastic. I'm the one that's having microphone difficulties now. So thank you so much for being patient with me while I scrambled to find a headset. My section is going to be on head and neck treatments and management of head and neck side effects. And head and neck radiation therapy is probably one of the hardest radiation therapies that patients can go through. Not only is the head and neck an exquisitely sensitive area in terms of pain and talking and taste and all sorts of items that really give us personality. It's also a disease site where changes in the side effect management can really make a big influence on the overall outcomes a patient has. We talk about quality radiation treatment, and sometimes we perseverate around whether this nodal level should be treated or not, or whether we should decrease a specific nodal level by 10 gray or not. But oftentimes, at Mayo Clinic, when we get referred recurrent patients from the outside, the number one cause, I would say that's the cause of recurrence, is patient had an unintended treatment break due to side effects from head and neck radiation therapy. They took a week off of treatment. They had 2 more weeks of treatment. They took another week off of treatment, and now they're 3-6 months out from therapy and their tumor's coming back again. So being able to stay proactive on head and neck management is super important. Being able to understand why the items of head and neck management are important are super important, and finding a good support network for these folks. I always get, yes, Dr. Holliday is saying it's the same with anal squamous cell carcinoma. I remember all those sit spads we had those patients in. These are challenging mucosal sites, either above or below. So engage a good patient support network early on. I get very worried when I see patients that are coming in and they don't have like a set care provider. Engage your social worker early in those instances. I often speak with the inpatient team early at that point, and I let them know that this patient, 3 to 4 weeks in treatment, is very likely coming in, and we may be keeping them in the hospital until they can finish their course of radiation. What we really don't want are the unmanaged side effects that lead to the treatment delays that lead to the tumor recurrences. It's also important to set expectations for the patients themselves. They get pretty beat up throughout their course of treatment, and the expectation is right afterwards, their side effects are going to get better, and that they're going to feel better and they'll be back to their old self. In fact, the rates of depression amongst head and neck patients within the 3-month period after radiation therapy is as high as 50%, partially because of this expectation issue. So I always counsel my patients, you will feel 50% of your old self at 3 months. But 6 months after treatment, you'll be feeling 75%. But 1 year after treatment's done, you'll be pretty close to where you were before. There's going to be some lingering effects of treatment. There's going to be some dry mouth. There's going to be some food items that you can't swallow well, but you're going to be well on your way to recovery. This is a marathon, not a sprint. So with that, why don't we go over to the first case, Jacob? This is a 62-year-old gentleman, lots of little cutaneous squamous cell carcinomas that pop up on the face. He gets those mowed out by his dermatologist every once in a while. His last Mohs is about a year ago, and he's found to have an intraparotid lymph node that's positive for squamous cell carcinoma. He has surgery and neck dissection, which yields a single 3-centimeter lymph node with positive ENE. He gets a 6-week course of radiation therapy, 60 gray and 30 fractions, the parotid bed. He gets 54 gray to the ipsilateral neck, and he has concurrent cisplatin as well. Next slide, please. So 3 weeks into the start of treatment, he starts to have some mild itchiness on the face, dryness, and diffuse erythema on the face. All right. Some of the items that you can consider thinking about at that point would be Vanicream, which is what we standardly use for skin management. It's important particularly with kind of the thinner skin of the head and neck, to let patients know, though, that when you're counseling them to put the lotion on, that you spread a thin layer of the Vanicream on and you dab it on, particularly as treatments go on, as they kind of try to massage the cream into their face. More times than off, they're sloughing off skin along with them, and they're exacerbating their dermatitis as that goes along. So definitely good counseling on how to put on their cream is important. Aquaphor is something that we use very commonly at the Mayo Clinic as well, although any of the hypoallergenic non-lanolin based creams work well in that respect. Particularly for the itching, we do find that mometasone cream, which is kind of a mild topical steroid cream, is helpful. We tend not to use that too frequently because mometasone cream for long-term application can start making the skin a little bit thinner, but we find that it's often quite helpful to use, particularly for the itching. There is a question that we have on there about asking patients to scrub off their cream before they receive radiation therapy. We actually don't ask them to remove their cream before the radiation therapy, just for the reasons mentioned above. Some of the reasons mentioned was patients they are quite diligent with the instructions that you give them. They will take a rag and start scraping across their face when you ask them to remove the cream. What we do tell them is, if you're doing the skincare, try to do the skincare after your radiation therapy is done. That way, usually the time course that you have between fractions is more than enough for skin absorption to take place and for the mild kind of natural exfoliation of the cream to occur. We don't really do long-term steroid cream use for the reasons mentioned above. Long-term steroid cream use both for risk of infection and both for risk of increased skin thinness. It is on treatment, short limited thing that we use mostly for itchiness. All right. More questions about skin management. So as the patient progresses into treatment, they're starting to have moist desquamation appear as well. And this is a particular challenge for head and neck patients because they're wearing a fairly tight mask the entire time that their treatment is going on. So they're going to have areas of moist desquamation appear that's getting constant manipulation on a daily basis, which is an introduction, it's a vector introduction for skin infections. So we often tell patients to start vinegar soaks at this time, which has a twofold effect. The first of so vinegar soaks are quite simple. It's just basically white vinegar, quarter cup of white vinegar soaked in with 4 cups of warm water. You soak gauze into that area. You put the gauze over the area of moist desquamation. Again, this is done after radiation therapy is complete. You let that sit for a while and then you gently lift that off. It does a couple of things. The first thing is that the gauze kind of attaches itself to the areas where the dead skin is located at. And when you peel it off is a gentle way to debride the area so that there's not lots of dead tissue sitting in an area that would seed for infection. The second reason is the vinegar itself is a little bit of an antimicrobial agent of its own right. It helps preserve the area and prevents infection. So we tell people to use vinegar soaks on a fairly regular basis, 2 to 3 times a day, once they start having moist desquamation appear. We do ask them to use Silvadene if there's some persistent areas that look like they might be foci for infection. Silvadene is something that you have to be a little careful for because it is a metal containing compound. And if you put it on before radiation therapy, particularly right before radiation therapy, the metal within the Silvadene can actually cause a little bit of a localized radiation reaction that makes the radiation skin reaction a little bit worse. So again, we tell patients to use a small amount for a focused area after radiation therapy is complete. There is some data. First, there's more complete data that's going on with Mepitel, which is kind of like a thin plastic stretchy film that goes over the skin. It helps lock in moisture and helps keep that area supple and kind of shielded from the environment. There's more data about it in the breast literature than there is in the head and neck literature. There is some emerging small studies in New Zealand and Germany about using Mepitel skin film for the head and neck. And we do have an ongoing clinical trial looking at the use of Mepitel film to see if that's helpful for helping decrease the rates and the duration of skin dermatitis for these patients. But that's something that we might see more data about in the future. Any questions about skin care before we get to the to pain management, mucositis, and nutrition? All right, next slide, please. So then in this case, for example, this is a 54-year-old gentleman. He has a T2N1 P16 positive squamous cell carcinoma of the left tonsil, getting definitive chemoradiation therapy off protocol to a standard dose, 70 gray and 35 fractions. Next slide, please. 3 weeks into treatment, they're starting to say, hey, doc, when I'm swallowing, I'm starting to notice something that would, I'm starting to notice some sensation in the back of my throat, particularly with harder items. Any items that people would like to do? Yeah. All right. So, usually at this point in treatment, we would transition them from kind of a more solid diet to a soft diet. getting your dietitian triggered in early at this point is very helpful, because one of the things that will be very easy at this point would be weight loss. We'll talk about weight loss more when we talk about the dietitian and nutrition and peg tubes and things like that. But you want to make sure that patients are keeping their oral intake up during this time. We'll transition them to a soft diet because mucositis is expected at this point, and do check inside the mouth for thrush. It is one of those things that can develop at this point. Once we have the soft diet, we usually use a viscous lidocaine based regimen. Dr. Sampson was talking about magic mouthwash before. Definitely check for compounding, and for pharmacies that have compounding charges that come along with things like that, we oftentimes just prescribe viscous lidocaine and have them just use viscous lidocaine, because that's the heavy lifter amongst the magic mouthwash solution. There is a viscous lidocaine shortage throughout the nation. Luckily, here in Rochester, it hasn't hit all of our pharmacies simultaneously. So when one pharmacy has a viscous lidocaine shortage, we're often able to send patients to different pharmacies and get that resolved. I saw a question earlier with Dr. Sampson's comments about that. We do use Doxepin on a fairly frequent basis, either as a replacement for viscous lidocaine, or when viscous lidocaine is unavailable, like when there's the viscous lidocaine shortage. Doxepin is a very interesting agent. It hasn't really caught on as much as viscous lidocaine, but there has been a phase 3 randomized trial run by Alliance looking at the use of Doxepin. It's a tricyclic antidepressant, actually, but it's not actually used for its antidepressant properties. It's used for its peripheral nerve properties when you rinse with it and gargle with it. It comes as a concentrated solution that you mix with water, and you use it 3-4 times a day. Patients, it has a different effect. It doesn't have quite the numbing sensation that viscous lidocaine has. So patients sometimes like that better when the dense numbing of viscous lidocaine is bothersome to them. It also tends to last longer than viscous lidocaine. Viscous lidocaine lasts about 15-20 minutes, whereas Doxepin can last 45 minutes to an hour. So patients tend to like that better. There are 2 side effects to watch out for when using Doxepin, though. One of which is the fact that you can swish and spit with it or swish and swallow with it. But if you swallow with it, it could make you a little sleepy. So for patients, we tell, throughout the day, if you want to gargle and spit, but at evening time, if you want to gargle and swallow, and that could help you kind of fall asleep a little better, that could be helpful. Also with Doxepin, it doesn't burn and it doesn't sting, but when you first gargle with it, it has this tingly sensation, this peripheral nerve, kind of almost like you have you bumped your funny bone type sensation inside your mouth, and some patients don't like that. So, these are side effect management drugs. So if patients don't like it, obviously switch to something else. We'll talk about gabapentin in a bit. So great question. Hold on to that. Next slide, please. Pain control regimen, we often start out with, simple things like acetaminophen, but liquid oxycodone is something that we transition to fairly quickly in the head and neck realm. Because again, when we get to the next slide about nutrition, keeping their weight up is super important. Liquid oxycodone is one of those things which I'm sure everyone here already knows about. Is when you prescribe it, be sure to have some type of laxative and softener combination that's used and prescribed. We do Senna-Colace here at Mayo to make sure that they are nice and regular when they use their oxycodone. What I tell my patients is the only thing worse than having a bunch of pain up here is having a bunch of pain up here and down there at the same time. And that's quite possible if you're constipated and you're using liquid oxycodone. Liquid oxycodone, once you start using at every Q4 hours, that's when we start thinking about adding on a fentanyl patch. Fentanyl patch is nicer because it's one of those things that once it reaches a steady state, it stays at steady state for a longer period of time. So you don't have that rebound effect that you have with liquid oxycodone, where you need to use it every 4 or 6 hours. Just be sure when you start the fentanyl patch with the patients to let them know that the fentanyl patch takes about a day to kick in. So if they put on the patch, they may need to take some overlap with the liquid oxycodone in the beginning. And even with the fentanyl patch on, they need to have the liquid oxycodone there for breakthrough pain if necessary. I usually start at 12.5 for a fentanyl patch. And once they start using the liquid oxycodone for breakthrough on a fairly regular schedule, I'll start bumping them up on their fentanyl patch as well. Gabapentin is something that has some mixed data within the literature. There are some randomized studies showing some benefit with gabapentin. There are some randomized studies that say there's less benefit with gabapentin. What I do find is that for patients that are narcotic intolerant, we often will do a trial of gabapentin to see if it helps them out in that respect. Gabapentin is a little bit of a touchier medication to use, though, for two reasons. The first reason is there's a titration period that's required to use for the gabapentin, and sometimes that takes a little longer to get up to speed. And the second thing is gabapentin kind of causes a drowsiness and slowness in its own right that seems to be a little distinct and unique from narcotic-based medications, and patients oftentimes don't like that either. So we don't usually use gabapentin as first line, but we will consider it for patients that are narcotic intolerant. All right, quick questions about pain management before we talk about nutrition. Now, nutrition and weight management, I consider to be one of the most crucial aspects of head and neck treatment. And this is when having a dietitian that's well within your team is super important. Having consistent messaging across the team is very important as well. I heard of an episode, for example, where the dietitian was counseling high BMI patients to lose weight in the middle of head and neck radiation. And they're like, why are patients losing weight? Just make sure that everyone in your team is on the same page when talking about how to do nutrition management. It's very helpful that patients keep a calorie diary when they're throughout radiation treatment, because when their taste is going down and it's painful inside their mouth, they'll be coming up to you and say, hey, doc, I'm eating 3-4 square meals a day and I'm still losing weight. Why is that? But if you really drill down into what's going on, they're eating half a hamburger instead of a full hamburger. They're eating half of a milkshake instead of a full milkshake. So what I usually have them do is at time of simulation, I have them start taking a calorie diary. So that when they start radiation, and particularly around the end of week 1, beginning of week 2, when their taste is starting to change, they can look back at that pre-radiation diary and say, this is how many calories and the size of portions I was eating before. This is the goal that I should have. PEG tubes are one of those things that we try to avoid as much as possible. And PEG tubes are challenging as well because it's dependent upon what the infrastructure at your facility is like. So definitely there are patients that they get really painful mucositis. They have problems at swallowing. It's 4 or 5 weeks into treatment. No matter all the interventions that you do, you need to put in a PEG tube. And if you're at a place where it takes them 2 weeks or so before they can get a PEG tube, that's bad news bears right there. So a lot of these places will do prophylactic PEG tubes, and I understand that certainly. But there are data that suggests that if you put in a PEG tube earlier and the patients start depending on the PEG tube earlier, their long-term swallowing outcomes are worse. So swallowing is a use it or lose it function. We encourage our patients to swallow as long as possible with their natural swallowing mechanism, even if it's gulps of water or something at that time, just so that they can keep the musculature supple and stressed throughout the course of treatment. And we will put in a PEG tube if necessary, but only if they're at the point where they're losing 5-10% of their body weight. I actually have a good cop, bad cop routine that I run with my nurse. So when they're getting to 3-4% body weight, when we're looking at their weekly body weight and I see they're going down, I'll walk into the room and I'll say, hey, man, you need a feeding tube. And then no one really wants a feeding tube, right? You know, you show them the pictures and they think it's worse than it is, but then no one really wants a feeding tube. And then my nurse will go up and say, no, I think they can get their weight up, Dr. Ma. I'm like, no, they need to put a feeding tube in at this point. And we'll have this exchange going. And finally, I'll make a deal with the patient that if they can stabilize their weight and get their weight up by the end of the week, I won't put on a feeding tube. And I'm usually surprised how well that routine works. But just Try to avoid a PEG tube if feasible, but if the patient really is losing more than 5 to 10% of their body weight, two things are happening. First of all, their immobilization is getting looser, because the first place that you lose weight is actually the fat pad in the back of your neck. So you may have to kind of rework immobilization. If they're on a proton plan that has huge changes inside their dosimetric qualities that you see, so you'll have to potentially replan their protons just to make sure that's looking okay. It's also less energy that the patient has for side effect recovery and for fighting off their cancer as well. These patients will take longer to recover. So I tell them food is medicine at this point. It's one of the medicines, just like the liquid oxycodone that you're using, just like the chemotherapy that you're using to get you feeling better and healing faster from treatment. So I'm running a little over time at this moment, but I think we do have some time for, I'll finish up the last slide really quickly and then open up for quick questions. So expectations again on improvement. Patients, just let them know that they may not have any recovery for the first couple of weeks after treatment, and that's okay. Pain improves after the first 4 to 6 weeks after radiation. Taste can recover after 6 to 9 weeks, but could be sporadic. Some parts of the taste might not recover as well as others. And dry mouth is a bit of a slow recovery. It can take months to years for dry mouth to get better, and not all of it will get better. All right, well, I think I'm over time, Jacob. I'll leave it to you on how you'd like to proceed.
Minutes, so still pretty close. Thank you for that. I like the point about really thinking about and knowing kind of the lead time at your institution, wherever anyone on the panel ends up working, about how long it takes to get a PEG tube, and sort of working that into your sort of mental equation, if you will, about whether or not a patient needs to get one. So yeah, I think that's all we have. I will open up the floor to questions for Dr. Ma or any of the other panelists at this time. I don't see anything else in the chat. We are tight on time, but probably have a minute or two for any burning questions. But if there's anyone thinking about things, these are just a few slides about Rover. Again, all of our contact information is here if you'd like to reach out to any of us about questions for future sessions, or to get in touch with panelists and things like that. We do record our sessions as well, if you'd like to use these as a study tool, or just something to kind of look back on too. So thank you again, everyone involved in this. The panelists, you're all excellent. And hope everyone here learned a lot. I hope there are a lot of new PGY2s and younger residents here that can really use this information for the new academic year. So our next sessions for this Rover joint session, the next one will be in August. And this is more of a non-clinical kind of applying to RadOnc residency session, really geared towards medical students. So this will be on August 18th, 7 p.m. Eastern. We'll have a variety of residents and attendings there. So if you're a student on the call, interested in applying to RadOnc, please stay tuned and join us next month. And as far as other clinical sessions that we have planned so far for the upcoming academic year, here's our running list. And the next one is MR guided and adaptive radiation therapy. So sort of exciting, newer technologies in the field. So again, thank you, everyone. This was an excellent session. We'll get to the rest of our afternoon and the weekend. Thank you.